And this is where the pre-treatment and DBT comes in. In DBT, this is where it differs from some of the other modalities.
Pre-treatment?
Pre-treatment.
Pre-treatment, okay.
Right. So like, let's say a client comes to me and they're interested in enrolling in comprehensive DBT. Before we start anything, before we start getting into true treatment, we will spend 4 weeks going through DBT. What is DBT? What's expected of you? What are the rules? We'll do a lot of educational work about like the biosocial model of DBT. So how was a borderline personality formed? So that can be a very validating as well as educational experience for people with BPD. We'll identify goals. We'll talk about a bit about what it means to live dialectically. We'll go through those assumptions that I was mentioning before about DBT. And then at the end of 4 weeks, we say, okay, I laid it all out here.
Now we start.
Well, no, there's one more step. Are you absolutely sure you want to do this? Are you sure?
All right, everyone. Welcome back. My name is Dr. Thomas Hughes. I am a child, adolescent, and adult psychiatrist here in Southern California. Welcome back to the No Supervision Podcast. I am joined today with Thomas Dunleavy, who is going to talk to us today about DBT. Without further ado, I'll let you take over. Let us know about yourself. What do you want us to know?
Thank you so much. So happy to be here and looking forward to speaking a little bit about DBT and its benefits and everything that comes with it. So I'm a licensed clinical social worker, and I am the founder of 3 Waves Psychotherapy. 3 Waves is a mindfulness-based therapy practice, and we specialize in the 3rd wave behavioral therapies. So dialectical behavioral therapy, known as DBT, also mindfulness-based cognitive therapy, and acceptance and commitment therapy, also known as ACT. At 3 Waves, we provide individual therapy, couples therapy, family therapy, in addition to comprehensive DBT, DBT skills group, and we also offer a 14-week CBT intensive group. So we serve people of all gender identities, age 16 and up. It is a telehealth practice, so if you're in California, we will be happy to support you and help you to achieve your goals. And personally, I have an interest in the treatment of borderline personality disorder, especially quiet borderline, which is a subtype of BPD. I have a specialized interest in anxiety disorders, emotion dysregulation, and distorted self-image, particularly within the LGBTQ+ community. So in short, I am passionate about helping people to learn how to use their emotions, manage their emotions, as well as provide the skills and tools that are needed in order to have a constructive framework for your thoughts so you can start to use them for you instead of against you.
DBT.
Yeah.
What does that stand for, the acronym?
Okay, so the acronym is Dialectical Behavioral Therapy. So DBT, as we break it down, dialectical is a philosophical term as well as a scientific term. Basically, an easy way to wrap your head around it is think about 2 seemingly opposite things existing at the same time. So it's not about either or, it's about the and. It's not about being black or white, it's about being gray. So as we approach our thoughts with this concept, if you think about, let's say you're graduating from college or high school, right? You could be so excited. So I'm so excited. I'm looking forward to the next step and where I'm moving to. And at the same time, I'm sad because I have to say goodbye to my friends, and I might be moving out of this town, which I have been in for the past 4 years of this college program. So we can see that there are 2 opposites there, right? That how can you be excited and sad as well? Well, because that's life, because life is not black or white. Life is incredibly complex. And that's where the freedom comes in, is when we can approach life from that place of balance and realistic, from being realistic about life, and that there are going to be many different sides to every situation that we're in. And especially when it comes to our emotions. I mean, of course, we have primary emotions, but It's very rare that it's ever straightforward like that. So when we can say, okay, this is complex, and we can approach it with a bit more balance, and we can be more gentle with ourselves, especially if we're navigating a difficult experience.
I got to ask you, DBT. You know, my first time I heard about DBT was in medical school. Okay? And I always tell people this: my experience with psychiatry, psychology was from movies and TV. That's what I knew about. And then I got into medical school, maybe my second year, because we had clinicals third year. But anyway, I didn't really know what it was about until maybe my third year. And the first time I heard about DBT, there was a patient, I believe, who was just having a very, very rough time, lost either his or her temper. I can't remember. And the doc that I was talking to said that this patient is doing DBT. And the doc that is doing the DBT, that's the only person on campus willing to do it. I said, what do you mean it's the only person on campus willing to do it? And then I started to hear more and more about DBT.
And did they whisper, oh, the borderline? Did like it's something like they whispered, right? It wasn't whispered because we were all in our office, and no one whispered it.
Yeah. It gets whispered in notes sometimes when we write cluster B traits. That's how it's whispered.
Yeah.
And I think nowadays, though, people are actually more willing to talk about borderline personality disorder. That is one of the benefits of social media. But I brought all that up to ask you this question, okay? Thinking back to when you first started working with patients with borderline personality disorder or DBT, what sparked your interest in it? After all the things I've heard about it, you pick one of the modalities that is notoriously one of the most challenging.
Well, I sort of fell into it, like with a lot of things in life. And for a lot of us, DBT just sort of presented itself to me. At the time, I was working in community mental health, and I was a hardcore CBT therapist, cognitive behavioral therapist. I loved my CBT, I still do to this day. Right. But then I had the opportunity to join my clinic. My clinic was interested in launching a comprehensive DBT program, and I was invited to be one of the founding members of that and help to get it on its feet. And being the education nerd that I am, and always willing and open to learn new skills and be able to support my clients in a new way, I said, "Yeah, let's go for it. Let me learn more about this." To your point, I very much had reservations at first, because you hear about borderline personality, and you oftentimes will hear the absolute worst, most extreme examples of that.
I would imagine this was the same because I'm a psychiatrist, you're a therapist. It's the same amongst both of our groups of people. Imagine
absolutely.
The reputation. Yeah.
Oh, absolutely, 100%. And I do believe that because of DBT, people are starting to open up and be able to understand that this is a very treatable condition, especially when we start to frame it and by acknowledging that this is a response to trauma. This is a personality that's been formed around early childhood traumatic experiences. So when we can approach it in that way and be able to understand the root cause of it, I hope, and what I'm seeing a lot of in our profession, is that people are starting to be more compassionate about it and more understanding. But absolutely, at first, that was the first when I was invited to be on the team. I did have to think a lot about it because, you're going to like the stereotype is you're going to work with the most intense, the most severe, the quote unquote worst of the worst, Yes, the therapy was created for people with BPD, and back then in the 80s when Marshall Linehan created it, the condition was considered to be untreatable. That's where a lot of the stigma comes from. So that's why a lot of people said, oh, they would just let people with BPD just be off on their own and, run themselves into the ground and burn out relationship after relationship. So nobody wanted to go near it.
Right.
But Marsha, she was researching suicide back in the late 70s, and then in the early 80s, she started to look into different approaches to help to address these very serious, life-threatening conditions. And then she came out and was very open about the fact that she had BPD as well.
Oh, she has it.
Oh yes,
Or had it or has it. Yeah.
yeah.
Wow.
Yeah.
Okay.
So she's been very open about that, and then through her study in Zen Buddhism and behavioralism, she started to look for some parallels between behavioralism, which was of course very popular in the 70s and 80s, and more the humanistic approach. And what she found was that it was the balance, the synthesis of the two, where you could get the most effective treatment results. From behavioralism, a lot of times a client would hear that and what they would take away from, oh, it's all my fault, right? But it's, again, going back to the dialectic, it's much more complex than that.
Right.
In DBT, we have an assumption that though you might not be responsible for the pain and the hurt and maybe even the chaos in your life, though you might not be responsible for that, you are responsible for cleaning it up. So it's that dialectic there, and then that's often a hard pill for a lot of people to swallow. But when we can take a step back and understand that it doesn't just end there. Another assumption in DBT is that people are doing the best they can with what they have available to them,
Right.
and you can't hold people responsible for something that they don't know.
Right.
Right?
Yes.
At the same time, even though many of us want to improve, we want to be better, we want to get out of hell, we no longer want to be in a place of suffering, oftentimes we have to make changes in our life. We have to be willing to do better, try harder, take a different approach in order to see the results of what it is that we want to have in our life, right? In order to get out of hell, you're going to have to do some stuff in order to make that happen.
Well, you have to put in some work to actually make some
Yeah.
changes in your life. In terms of what a person needs to get out of DBT, what are the things that person can do to maximize the benefit of engaging in DBT?
Well, the first thing is to acknowledge that DBT, a lot of people come into DBT when it's the end of the road. I can't even tell you how many clients I've worked with who have said, I have tried this, I have tried that, I've tried psychodynamic, I've tried every medication management, I have tried everything, and yet I still end up in the hospital. I'm still not able to manage my emotions. I'm still engaging in suicidal and self-harm behavior. I don't know what else to do.
Before you continue, question about for those people, do they know that they've been diagnosed with borderline personality disorder?
Some do.
Okay.
Some do.
I'm always curious about that.
No, but many don't.
Right.
Many don't. They only see the effect of what's happening. They only see that, like, I'm not able to manage my emotions, and I'm ending up in the hospital, and people don't want to be around me anymore, and I'm lonely and isolated, and I feel empty inside. So a lot of times those people will feel like they're the only ones. I'm the only person in the world who feels this way.
I wonder
going
if they
through
look
this.
through their charts, what they would see in their diagnostic codes. I wonder. That's
well,
why I asked that.
Yeah, well, a lot of people with BPD have been misdiagnosed. A lot of times they're diagnosed with bipolar when that's not what's happening. It can be better explained by BPD.
Right.
Men and women generally, general terms, a lot of men will be diagnosed with more of narcissistic personality. They will be even antisocial. They'll be misdiagnosed in that respect. Women and for men, it'll oftentimes manifest through substance use, or like their impulsivity will come out through sex, substance use, stealing. Where with women, it tends to be a bit more introverted and directed inside. Where men might not take any accountability, and they might say, "Oh, this person's to blame, and that person's to blame, and this isn't my fault." Women, on the other hand, women with BPD oftentimes will internalize it themselves. And then where with men, it'll come out more through substance use. For women, it's more through eating disorders.
Very interesting.
Yeah. So a lot of times people have been, again, going back to your original question, many people have been misdiagnosed with bipolar, ADHD.
Or not told at all.
Or not told at all.
That's my thing. We just didn't. Again, the cluster B traits was all in the charts instead of actually saying borderline personality disorder. I just feel like the conversation is very difficult to have with people. And I think that was more of our hesitation versus theirs, because they don't even know what it is usually.
Right.
But anyway, I took you off course. You were describing the factors. I go on. I told you I'm out of practice. I'm on these tangents.
It's all good.
But I was asking what parts or what factors are involved that allows for a person to do better. You were describing people that end up coming to you after they've been hospitalized multiple times. And
Right.
So sorry. Right.
Yeah. So a lot of times people come into DBT and they're like, this is the end of the road. I've tried every other treatment option. I don't know what else to do. So in that, there is a necessary willingness that a lot of times people will come in and say, okay, I can't play around anymore. Like I'm getting really serious about this. So I think that really will influence treatment and especially outcomes is the willingness, the openness, and the receptivity, because DBT it's for all of its constructive effects and all of the benefits that come from DBT. This ain't easy work. It's not, I mean, we're talking about changing behavior and we're talking about behavioral patterns that have been there for decades and have been reinforced over and over and over again in romantic relationships and professional relationships, in your worldview and how you see yourself. So this is not for the easy-hearted,
Yeah. So I've been told. That's why you're here. So
well, they say that at DBT we go where angels fear to tread, and I think there's something very powerful in that. So I think that it does require openness and willingness, and this is where in pre-treatment and DBT comes in. In DBT, this is where it differs from some of the other modalities.
Pre-treatment.
Okay. Right. So like, let's say a client comes to me and they're interested in enrolling in comprehensive DBT. Before we start anything, before we start getting into to true treatment, we will spend 4 weeks going through DBT. What is DBT? What's expected of you? What are the rules? We'll do a lot of educational work about like the biosocial model of DBT. So how was a borderline personality formed? So that can be a very validating as well as educational experience for people with BPD. We'll identify goals. We'll talk about a bit about what it means to live dialectically. We'll go through those assumptions that I was mentioning before about DBT. And then at the end of 4 weeks, we say, okay, I laid it all out here.
Now we start.
Well, no. There's one more step. Are you absolutely sure you want to do this?
Wow. Okay.
Are you sure? Because this is not always going to be easy, and it's not.
Wow. So you do pre-treatment, and then you have to stop for a second to say, listen, it's gonna get. This is just a start.
Yeah.
Right?
Oh yeah.
Do you want to do this?
Do you want to do this? Are you sure you're game for this? And there are other ways, other approaches that you can take, but DBT is not for everybody. It takes a lot of commitment. There's a lot of work that's required. We are going to be reviewing diary cards every week. The diary cards are very detailed, so you're going to have to sit down and do your diary card. I suggest once a day, but you're going to have to complete them before the end of our sessions. You're going to have to attend skills group, which is where you're learning all the new DBT skills, and be willing to call in for phone coaching when you need it before you engage in your target behavior. So it is intensive, it's rigorous. It's for something that's built on this whole dialectic, the whole gray and fluidity. It's very, very structured, and we have very clear rules and protocols that we take right down to our therapy sessions and what it is that we'll talk about and the levels that we talk about them.
That is shockingly, what word am I thinking of here? I'm trying to think of the word here. It's overwhelming. I'm overwhelmed.
Hey, it can be.
Yeah,
I'm
overwhelmed.
Hey, when I first started learning this, I mean, if you just look at the manual, the DBT manual with the handouts and the worksheets, it's huge. It's sort of like a running joke and with therapists. It's like this book that the clients are required to have is huge. So it is overwhelming, and there's a lot to take in. A lot of acronyms. DBT loves an acronym for all of our skills. Right. And here's the and is yes, it's a lot, and you don't have to get it all instantly.
Right.
That's why we recommend treatment for at least 1 year.
That's what I was going to ask you. How long does is it on average?
The 1 year is the standard. It's really what's most encouraged.
Okay.
A lot of times therapists might meet you halfway and compromise at like a 6 month, and then we revisit at the end of 6 months. But 6 months is really the minimum because you are going to be in individual therapy, which is where you're having your one-on-one with your therapist, but you're also going to be participating every week in DBT skills group. That's really where you're going to learn the skills, this new way of showing up in life. So we recommend a year because about 12 to 14 months, that's going to be enough time for you to go through the skills at least twice. Because the first time you're going to just be taking it all in, and especially once we start to introduce some of the mindfulness topics, it could be a little heady. It could be a bit esoteric. It could be hard to wrap our heads around it. So you will need to go through it at least twice. And what I tell my clients is that this is a journey, right? It's sort of like a lifestyle. You're learning a new way of showing up in life. So there's always going to be more that's going to be revealed. You're going to constantly be. I mean, even to this day, when I teach the skills every week. It's something I'm passionate about. I study them. I live them. I live this lifestyle myself, and I'm still learning the power of the skills because they're going to hit differently at different times of your life and different scenarios and situations that you might find yourself in, right? Yeah. So it's like with anything else, you're going to be peeling back the layers, and the learning is never going to stop.
Right. I think one thing that I will say, because I've never performed DBT, and I only did 3 years of general residency, and then I did 2 years of child. And I think usually, if you're a psychiatrist, if you wanted to learn DBT, you might do that in your 4th year. I didn't really have a 4th year. But from my understanding of it and from what I've seen from patients, it's very, very effective. I said it's overwhelming because, well, it is. But then when you look at the issues that people are having when they have borderline personality disorder and maybe even other conditions too, that's what it takes to put yourself back on track.
Right.
That's kind of how I think of it.
Right.
But I don't think I've had the explanation that you gave today to actually explain why it's so intense. That's why. Yeah.
Well, again, look at what the therapy was created for, and oftentimes what leads people into DBT. Ending up in the hospital after a suicide attempt or suicidal ideation. That's intense. Yeah. Right.
And then multiple times too. Sometimes
multiple times, and even the trauma that goes with that. Like, this is intense. The impact of growing up in an invalidating environment, or being in a relationship that might not be supportive or constructive to you, or maybe even not having any relationships. Maybe you've burned out a lot of the key relationships in your life, and now you're isolated and alone. That's intense as well. Yeah. Right. Yeah. So it only makes sense that an intense treatment is going to be needed for something for intense conditions.
What are the biggest challenges that, and I want to take this in 2 steps because you're important too. What are the biggest challenges that a patient might experience? And you can give maybe 1 or 2 or just 1 if that's the case. And then even for you, what are the biggest challenges that you've experienced when you're actually using the modality with people?
Yeah, one of the biggest challenges for a patient would be patience. A lot of times we want instant results. We hear all of the amazing outcomes from the research, and people who might enroll in DBT treatment might say, "Oh, I knew this person. They went through DBT, and their life is completely different. They're living this amazing life, and I want that for myself." And then they get into treatment, and they're like, "Well, why aren't I fixed? Right? Why isn't everything better?" Because this is a process.
Fixed is an interesting term too. I hear that a lot also. Yeah, fixed.
Right. Yeah. Right. And I think it depends on what your definition of fixed is, but I think that could be a slippery slope.
We get what they mean by that. But I think also for mental health professionals, the idea of fixing something, it's almost like you're not broken. It's like That's kind of how I think most of us approach sort of that comment, but we know what they mean. You know?
Right.
Yeah.
And that's the thing, is that DBT is a blame-free model. So no, you're not broken. You just might not have the skills that you need in order to show up in challenging situations.
Right.
You might not know how to go after your goals, or how to manage your emotions, or what to do when you're just overwhelmed with emotions. So it's about a skills deficit. But as a behavioral therapy, I mean, we acknowledge that no problem exists without a solution.
Right.
That's one of the things that I love about DBT.
Okay.
So patience, right?
Yeah.
Clients have to be patient. They have to, and that's where pre-treatment comes in. Like, you have to understand exactly what it is that what you're signing up for, and what this process will likely look like. So patience can be a big challenge. And again, DBT is extremely structured. So doing diary cards every week, and attending group, and being vulnerable and open to reach out for phone coaching when you need it, that's not for everybody, right? So understanding what's expected of you in order to get those results, and being able to manage expectations as well.
So those are good things for us to know for the most challenging things that patients experience when they're undergoing DBT. What about you as a provider or colleagues? What's the most challenging thing that you can think of?
Stereotypes exist because in some respects there can be truth in them, right? So oftentimes people, it depends on the symptoms and the challenges that the client might be experiencing. But we're talking about people with who have a very difficult time being able to regulate and manage their emotions. So, and primarily the emotion of anger. So a lot of times that anger is explosive and can be directed towards somebody who might be safe, and where they might feel like, well, if I lash out at this person, they're not going to leave me. So tying into that fear of abandonment that we see a lot with people with BPD. So oftentimes we can be the target for that anger. In my experience, that's happened rarely. It has happened, absolutely. But in my experience, that happens rarely. But you again, just like how the clients need to be patient with the process, this is where therapists need to be able to take it one step at a time, and to remember that this is a process as well.
Right.
And there are a lot of different factors that we're navigating here. So because you are dealing with, especially with life-threatening behavior as well, for clients who come in with those really severe conditions, as far as suicidal thoughts or self-harm behavior, it can absolutely take a toll on the therapist as well. So this is why in DBT, we have a requirement for comprehensive DBT that the therapist is required to be on a consultation team. So this is where we meet every week, and we're not only ensuring that we're practicing high fidelity DBT and staying in alignment with our values and protocols, but it's also known as therapist for the therapists. And this is where the DBT therapists are able to get together and be like, oh, I need validation right now, right? And we say, what do we need? Do we need to update on a case? Do we need to help problem solving, or do we need validation, right? And so this is where we might be able to talk a little bit about what's going on inside of us. So
it's one of those things that, again, I just didn't know until you're in the field. Usually you see, again, TV, movies, even if you know someone that's a therapist, you only think about the therapist doing therapy. You don't think about what happens once the session is over.
Right.
Therapists and psychiatrists, they have their own personal issues too. They're worried about whether or not they're providing the best of care.
Yes.
So I think there's some imposter syndrome involved with that too. Yeah, there's a lot to it.
And fear. You know, like that's another thing that at least I can only speak for myself, but I care a lot. Tremendously. I care tremendously about my clients and the people that I work with, especially in DBT, because it is so intimate. So it can be scary at times when somebody calls and that they might be engaging in their target behavior, or they're suicidal at the moment. These aren't easy calls to get, no matter how many times you've gone through it, and no matter how prepared you are for it. We're human. You know,
Yeah.
we're human beings as well. So that's where it's important to practice our own self-care and to be able to embody a lot of the principles of DBT as far as balance goes and observing limits.
You mean practicing what you preach?
You know,
Really?
just a little something
Really?
like that. A little something like that.
Yeah. Doctors, not therapists. Doctors are the worst. Really.
No, I think you might be idolizing.
I'm not.
Idolizing some
I'm
of the therapists
telling.
as well.
Well, maybe. I'm referring to our health restrictions and our health guidelines and the stuff because I hang with docs, right? The stuff we eat versus what we tell other
Right.
people to eat doesn't match.
It's the whole do what I say and not what I do, right?
All right, so I don't know if we covered in depth about because we mostly talked about DBT and it's what it does for borderline personality disorder. Is there something you want the public to know about borderline personality disorder that isn't much talked about?
A few things, yeah. That one is that it's not always as severe as you see in the movies.
I agree.
And
Yes.
and people say, "Oh, I was Googling borderline personality," and look again. On one hand, it can be very validating. People might be able to say, "Wow, this cluster of symptoms, like it absolutely explains what's going on inside of me." And I thought I was all alone, and I see that almost 2% of the population struggle with this. And so in that respect, it can be very validating, right? On the other hand, just like any other type of research on the internet, you gotta be careful. It's like you have a headache and you Google that and it comes up all of a sudden.
Now you have a tumor.
Yeah,
Exactly. It's all
exactly.
sorts of stuff. Yes.
So do understand that it is a spectrum. Okay. Again, like with any stereotype, sure, those really severe cases that a lot of us know about and have come to represent people with BPD. Sure, it happens, but there's such a spectrum and it's so wide and varied. So, and to practice again some non-judgmentalness around it, right? That this is a condition that was born out of trauma. These are people who are at a skills deficit, and they're being held to an unfair standard that they're just told to be able to manage their emotions. Well, but were they ever taught how? Right? Get it together. Well, were they ever taught how? Or don't cry, get over it. Okay, well, you're oversimplifying the process. If it were that easy just to get over something, most people would.
Yeah.
Right? So again, going back to understanding that there's a reason for this. And at the same time, there's help to support it, right? Going back to that concept that we're all doing the best we can with what we have available to us. And a lot of times we need to try harder, do better, and make changes in our life in order to prevent, these outcomes from continuing. So, you just like how somebody says, oh, I'm just depressed, or I'm anxious, or I have bipolar, or I have BPD, so this is just who I am. Well, okay, and there's something you can do about it.
Right. That's not a license to go and just
Right.
not work on yourself.
Right.
Okay. You still have a duty and a responsibility to other people and yourself actually to work on making things better.
That's exactly right.
Yeah.
Now, a lot of times, just like with any type of procrastination or any type of avoidance, it's rooted in fear, right? That's so when we're able to get to the heart of that and understand that there's some perception of danger that's there, again, we can better understand what might be going on for that person.
Okay. All right. So can you actually, I think you already did that. You painted a picture of someone with borderline personality disorder, I believe. If you were to step into the head and the heart of somebody who had BPD, borderline, I would imagine that to them they might see that the entire world and everything that they know is unstable. Okay, right down to their emotions. People with BPD have this like unstable pattern of being able to manage their emotions. So they might fly off the handle. They might go from like 0 to 100, and they might think that there's no in between. Right? I hear this all the time during my intakes. I just go from 0 to 100, and I can't stop myself. So already there's this very black and white mentality that's there. Right, so right down to their emotions. I can't trust my emotions. My emotions are unstable. Right, that black and white mentality. So we see that a lot of times with people with BPD as well. That it's either all or nothing.
right? Black or white. They'll be so into some type of goal or project or somebody, right? A relationship. And it might be the most amazing relationship in the world and the most amazing person. And I love this person forever. But if they don't text back fast enough, that boom, all of a sudden they cut them down, right? And so they're constantly like swinging from that, putting people up on a pedestal to cutting them down, or even different goals, projects that they might be working on. So even their interests are unstable. Their ability to know who they are. A lot of times people with BPD, when all is said and quiet, there's a sense of emptiness that's there. And they might say, I don't know who I am. And because of that, they might change who they are depending on who they're with in order to get that person to like them. So they'll stick around, right? So their relationships are unstable. Their ability to see themselves accurately is unstable. Their ability to manage their emotions is unstable. So then what happens is that because it's very extreme and they're always in one end of the spectrum or the other, that's going to burn you out. So then it's no longer there's not a whole lot of safety in their life. They don't often feel safe. So then we enter into like difficulties trusting other people. Right. So we see like this pattern of mistrust, like no matter what my girlfriend says, she says she's not cheating on me. She said she's just going out with her friends, but I'm still going to break into her phone and scour her social media and look through all of her media, her emails just to see and look for anything that might confirm that's right. See, she is untrustworthy. So it'll oftentimes lead to that impulsivity because there's like a desperation there. So
and it's a collection of all those things, not just one of those things. Right.
That's exactly right.
Okay.
That's exactly right. So because it's the difficulty in being able to manage their emotions will override their brain, and that part of the brain that says, hold up, wait a minute. Let's put this in perspective, right? Because the amygdala, the fear center, is constantly going off and firing danger, danger, danger. Well, then that person is going to be very reactive. You know, it's like if you're walking through the woods or and a bear comes charging at you, you know, think about what happens. You don't really say, "Oh wow, what look at this! Look the 5 different colors of brown I see on this bear." Oh, I would say that bear is about 8 feet tall, and you don't do that, right? You immediately go into fight, flight, freeze, or fawn, right? Your 4 stress responses, trauma responses. So that's because the part of the brain where you're able to conceptualize and contextualize and be able to put it in perspective shuts down in order for you to survive. You're fully in survival mode. So when we apply that to the person who is engaging in impulsive behavior, right? And when it's being fueled by that fear of abandonment, the fear of rejection, it helps us to better understand that for them, you know, sometimes people say, oh, you know, they just, it's the smallest thing, it's the littlest thing will set them off. Okay, maybe, but to them, it's not a little thing.
Right.
To them, this is huge. This is life or death. So of course their response makes sense.
Their amygdala, their brain is primed to respond to certain things, which ties back into what you spoke about with trauma.
That's right.
You know, you mentioned about five different things about either or, black or white, that connects back to what DBT does in terms of helping people find essentially the gray area.
That's exactly right.
Things. That's why
exactly
DBT
right.
works.
Well, yeah, especially for the, you know, a cluster of symptoms like this. So the foundation of DBT is mindfulness. So this is our ability to be able to be with reality as it is, right? And to be able to say, okay, this is happening, right? Acceptance can has been confused often, and mindfulness sometimes can be misunderstood. But it's really just our ability to make room for what is happening and saying, yep, this is happening, or I'm experiencing this emotion, or I'm noticing this thought. So it's our ability to just acknowledge that and not to automatically think that just because you're thinking or feeling something that it's a fact. So mindfulness helps us to separate from our thoughts and our emotions. And then in that sense of separations, we're able to look at it with curiosity and compassion and say, interesting, I'm having the thought, I can't do this. And then we just kind of sit back and we just sort of look at it and we just kind of think about it. I can't do this. Well, is this a fact or an interpretation? Is this an assumption? Right? Well, what's showing that what I can? What are the facts the evidence that would say that I'm not able to do this? And that's what the issue is. A lot of times, because we don't have a pattern or some type of system to be able to experience our thoughts and our emotions in the most constructive way possible, they just run the show. Right? So we believe every thought that comes in. I think they said 50 to 70,000 thoughts we have a day.
What?
50 to 70,000 thoughts a day. Can you imagine if you just responded to all of his thoughts?
No.
Right.
I don't want to.
Believe me, neither do I.
I'm overwhelmed again.
Exactly. So mindfulness helps us to be able to separate from all of that and be able to acknowledge and notice what's happening. And then from there, we're able to move into the next step, which is change. Okay, so what am I going to do about this? I'm accepting that I have this thought or this emotion is here or this challenge. And then so from that place of acceptance, we're not resisting it. We're not pushing it away. We're making room for it. And we're saying, okay, so what am I going to do about this? So mindfulness is like the foundation. We see it in just about all of the skills that we practice in DBT. It shows up in the other 3 modules of DBT. So that mindfulness will help people to step back and not be so impulsive, right? So we start with that. But then going back to the concept that the theory behind people with BPD is that it's a skills deficit, right? This is just how they're going about getting their needs met because they don't know any other way. So when we look at the intensity of the emotion, right, and we look at what happens as a result of that. So I was just so angry that I broke that glass. I threw it against the wall and I broke that glass. Well, what's the function of that behavior? What was that person trying to do? Maybe to be understood, maybe to have a relief and a release from the pain that was going on inside of them, the frustration that was going on inside them, right? So to address that, the intensity of the emotion we have at the top of the hierarchy here is distress tolerance. So we have a whole module built to simply to help you get through a situation or a trigger without making the situation worse, and for getting the emotion down in a healthy way. So then eventually we can, once the emotion gets down, because we're not going to try to problem solve and do all of that when the emotions...
When you're up there, when you're going at 100 miles an hour. Yeah.
Right.
Okay. Yeah.
Right.
Yeah.
Once the emotion does get down, we do need to go back and look at what was causing the emotion to get so high to begin with, right? Like you can throw ice into a pot of boiling water all you want, and it'll reduce that boil to a simmer for sure. But eventually, if the pot is still on the flame, it's going to start to boil over again.
Right.
So what we need to do is we need to get that boiling down, so then we can remove it safely from the fire, and we can address what's causing the emotions to get so high to begin with. So we have a whole module dedicated simply through that, how to not engage in your target behavior, other ways for you to find the relief that you need other than through substance use or self-harm, or whatever the behavior is that you're looking to correct. And then once the emotions are down, then we move into the emotion regulation module. These are the skills that we learn, where we start off by learning the functions of our emotions and the purpose that they serve in our life. This is where we learn how to change our emotions once they start, and also how to encourage more of the emotions that we desire in our life. So it's not about not having any urges. It's not about not having any emotions, because that's unrealistic.
Exactly.
We're human beings. Our emotions serve a function. They communicate to ourselves. They communicate to other people. They motivate us into action. So we need emotions.
That's one of the toughest things, DBT, CBT. I don't care if you get angry. It's what you do when you get angry that matters.
But do you see what happens though? People will take the behavior to demonize the emotion, but the emotion's not the issue.
Right.
It's the behavior that comes from it.
Exactly. Yeah.
Right? And it's very difficult to be able to use our emotions for us if we're sitting there judging them and saying, "Oh, envy is bad," right? Or anger only leads to destruction. No, that's not true. Anger is there to show you that something important to you is being blocked, or maybe there's been an insult.
Yeah.
Right? Envy is there to say, "Oh wow, look at Thomas's awesome posters. These are so cool. Look at all this artwork. Oh, I would love to have that." Well, that's communicating to me that this is something that I enjoy and that I like. But if I say, "Oh, envy. Oh no, people who are good aren't envious." Well, I'm never going to be able to use that power of envy to be like, "Oh wow, yeah, like, yeah, this is I would, I really like Marvel and I really like the Voltron, whatever it is, right?" Now, of course, I'm not saying that that's actually me.
It's okay. No, it's okay.
No. But do you hear what I'm saying,
Yeah,
though?
absolutely.
If we're sitting there judging things and saying, classic example, this is classic mood dependent behavior, right? I'm too scared to do something new. Right, I'm too scared to go on a job interview, or I'm too overwhelmed with fear to go to that party. Okay, well, what's the fear telling you? Fear is our perception of danger.
Mm-hmm.
Okay, so now what happens is we use our mindfulness skills to step back, label it for what it is, which is, okay, I'm experiencing fear.
Mm-hmm.
Fear is my perception of danger. Is there anything here, any facts that are indicating that if I go on this job interview, that I'm going to be in danger? And then people start saying, no. Well, but I'm afraid of getting rejected. Oh, okay. Well, great. We could do something about that.
Yes.
Right? There are skills to help with that. And there are ways for it to be able to better understand it. So once you're able to work through it, then you can start to give yourself what it is that you need. So you can start to allow the fear to be there and still take action anyway towards what's most important to you.
Yeah.
And these life worth living goals that we talk about in DBT.
Well, we have, thank you. Whether you inadvertently or purposefully complimented my posters. Thank you. I'm not gonna lie. Everything you said went out the window. As soon as you said that, I just focused on the compliment. I'm kidding.
It is beautiful. It is beautiful artwork.
Okay. So, are there other uses for DBT other than for?
Yes,
Borderline?
absolutely.
What are the other uses?
Well. So then, one of the fourth module in DBT is interpersonal effectiveness. So,
Okay.
because going back to how we were talking about how people with BPD oftentimes have challenges and unstable relationships. So we have the interpersonal effectiveness module to help to strengthen relationships, how to release unhealthy relationships, how to ask for what it is that you want and need, and how to be able to maintain your self-respect through it all. So when we look at the four modules, mindfulness, how to be more present, how to be more accepting of what is, my personal definition of mindfulness is the non-judgmental awareness of what is experienced in the most compassionate way possible. Okay. So we've got mindfulness, distress tolerance, how to get through a crisis or difficult situation or an urge without making the situation worse. Okay. Next module, emotion regulation, how to manage our emotions, how to encourage the emotions that we want more of in life. Okay. Fourth one, how to improve relationships with ourselves and other people. Take away what the therapy was created for, right? People who are chronically suicidal.
Mm-hmm.
And aren't these just basic life skills that anybody could
Yes.
benefit from?
Yes.
Right? Like,
Yes.
I want to be more present. I want to have, more rewarding relationships. I want to feel my emotions and still take action towards my goals as well. Right? I want to learn how to be able to roll with difficult situations when they happen. It's going to happen to all of us in life.
Mm-hmm.
Like with the Buddha taught, right? Pain is inevitable, but suffering is optional. So if we're able to understand that pain happens in life, well, I'm going to need the skills to know how to navigate that pain when it happens. So this is what I tell my clients. These are just solid life skills. They're solid life skills. They're something that can benefit anybody with or without a mental health condition. Right? It just helps us to be able to experience our life in a more fulfilling, rewarding way based off of our values, what's important to us. Okay, so you don't need to have BPD. You don't even need to have mental health concerns in order to benefit from DBT. This is where the whole lifestyle component of it comes in.
Mm-hmm.
But the research does show how effective it has been, not just for BPD. Recent studies show that after 1 year of comprehensive DBT, 77% of people no longer meet criteria for borderline personality. And after 2 years, 88% of people no longer meet criteria for BPD. So we see how effective it is for BPD. We see how effective it is for people who struggle with frequent and chronic hospitalizations and self-harm, eating disorders, substance use,
Right.
how effective it is there. But also for anxiety. Going back to the functions of our emotions, right? A lot of times anxiety will keep us in the future. Well, what if this and what if that? And what if she says this and what if she says that? Well, what happens if you come back to what is, right? Come back to this present moment. What is that what do you know right now?
The mindfulness aspect of it.
That's the mindfulness aspect of it, right?
Yeah.
And then in DBT, we have a skill called cope ahead, which is where we say, okay, so let's say you're going into a very activating situation where there's a likelihood that you're going to experience fear. So what are we going to do about it? How can we use this understanding that you're going into a challenging situation for your betterment? This doesn't have to paralyze you.
Right.
We can use it to help you. So, okay, so what is it that you need? How can we prepare for this? Where's your system of support? Different mindsets that could be helpful for you, different somatic ways to get yourself to relax and reclaim that sense of safety, even in the unknown. So it can be incredibly effective for the treatment of anxiety, certainly for panic disorders. I mean, that's the whole distress tolerance module.
Right. Yeah.
When somebody's panicked, the panicking, that it's just this overwhelming, intense fear, right? This debilitating fear to the point where they feel like I'm dying, I'm having a heart attack, or they go to that place. So that's why we have the distress tolerance module.
So you have, whether you have BPD or not, anxiety or not, OCD, anything, they should call you. I think.
Yeah, well, yeah, I will be happy to support
I'm motivated to do DBT is my point.
Yeah, okay. Well, let's set up some 4-week pre-treatment sessions here, Thomas, and we'll see.
All right. So if you're looking to get motivated to do DBT, how can people find you?
Absolutely. So my website is 3wavespsychotherapy.com. So 3 waves with an S at the end, psychotherapy.com. You can feel free to email me, Thomas, at 3wavespsychotherapy.com, or you can feel free to give me a call.
Do you have a number that you want to put out there?
213-583-2170.
Okay. And are you doing only tele or are you only in person? Do you do both?
So at this time, I'm only telehealth.
Okay.
So all of our services, including DBT Skills Group, is online, are online. So they'll be sent a secure telehealth link. And so if you're in the state of California, we'll be able to support you.
Okay. Thank you for coming in. I appreciate it. And again, Thomas has given you your information or his information. I'll put it all in the description for you to find him. Thank you so much for tuning in. Tune in next time for the next episode of No Supervision.
Thank you.
Great job.
Thank you.